everyone. It's great to be here. I'm really grateful to the organizers for inviting me to this conference. This is my first EA conference, and I'm quite keen to hopefully interact with all of you after this session and get some of your feedback on whether I'm being accurate in the parallels that I'm going to try to draw between my work in global health and priority setting from more of a government point of view, and what all of you are a lot more familiar than I am in terms of effective altruism. This is going to be quite an introductory talk into cost-effectiveness analysis, and I'll be focusing primarily on how I use cost-effectiveness analysis and priority setting focused on global health, and give a few examples of what I've done in the past. Just in a little bit of an acknowledgement, some of these introductory slides come from some short courses that we run at the School of Population and Global Health on cost-effectiveness analysis. So if this is an area that you're interested in learning more about, feel free to check out the link to have a bit more of a look. So this is what my talk will cover today. I'll start out with a bit of motivation for why cost-effectiveness analysis and economic evaluation as a whole is quite useful in global health. I'll talk about what cost-effectiveness analysis actually is, and then focus a little bit on the methods that are used and some of the key aspects of cost-effectiveness analysis. I'm not going to focus on the costing part at all. I really want to focus on how we define effectiveness and outcomes for cost-effectiveness analysis. I'll present a few examples of applications to global health, and then talk about some of the particular challenges and directions that this field is heading in that are quite interesting for me personally in my research, and I would think quite interesting for those of you who care about effective altruism as well. I'll try to tie in some of the parallels that I can see between what I do and EA, but I'm quite keen to hear from all of you as well about that. So a little bit of food for thought. I'm sure you've seen something similar, if not this, in the past. So this is just a way to show productivity in one sense. What you can see here on the y-axis, the vertical axis, is a measure of health outcomes. In this case, it's life expectancy. It could be something different. And on the x-axis, we have per capita healthcare spending in international dollars. So these are dollars that are comparable across countries. So each dot here represents a country in the world. And as you can see, this allows us to sort of compare what we're getting in terms of overall health. Life expectancy can be seen as one measure to measure our health as a society, given the amount of spending that our government is putting into the healthcare system. And so you can see here Australia, that's highlighted, but there's some clear countries that are always used as examples in this field. So we often talk about Cuba, that's spending very little per capita on their healthcare system and achieving quite remarkable health gains in terms of life expectancy. The other outlier that everyone always talks about and enjoys to talk about, I think, is the United States. That tends to spend quite a lot per capita on health care, and doesn't quite seem to achieve the same health gains as some other high-income countries. And there's a lot of different reasons that could potentially explain this. But in general, the trend that you see is that the more we spend on health, generally, the more health gains and health benefits a society achieves. This is quite similar to what you just saw, but it's slightly different. So here now we're organizing health interventions according to the value of the interventions. So we've organized these according to starting with high value interventions, moderate value, all the way down to low value care. On the y-axis again is some measure of health. So in this case, it could be QALYs, it could be life expectancy, it could be DALYs averted. But in general, what's important to note here is the slope of the line, the slope of the curve. So when you talk about high-value interventions, we're getting a lot of gain on our y-axis per increment on our cost axis. So per dollar spent, we're getting a lot of value. As we go this way along the curve, we're getting less and less outcomes or health gained for the amount of money that we're putting in. And you probably hear the term flat of the curve medicine, where you're sort of approaching very little incremental gain in health for the amount of dollars that you're spending. And then you've probably also seen a lot of reports that have come out talking about the harms that actually can be achieved from unnecessary or harmful medicine or treatments or programs that are in place that could lead to adverse effects. So overtreatment, too much spending that's actually causing harm. So why set priorities? Again, my focus is really on government priority setting, but we could be thinking about organizations, non-governmental organizations, or community organizations as well. So in general, healthcare is good value for money. I showed that first curve where in general, the more you spend, the better your life expectancy or health gains generally are. But the important thing to note is that not all healthcare is as good value as the average. So that's what the last graph just showed with the decreasing slope. So the main motivation for priority setting in health and the use of cost-effectiveness analysis as one input into priority setting is that resources are limited. So this could be financial resources, but it could be healthcare professional resources, it could be land area, it could be number of beds in a hospital. There's a wide variety of resources that are relevant in terms of population health, but these resources are limited. So we cannot, countries, governments cannot afford to provide all the resources that they would like to provide to all people in their country or to their society. And it's also true that the cost of healthcare is likely going to increase over time. So new technologies are emerging, new drugs, quite expensive drugs, new vaccines are emerging against malaria or against HIV potentially. And all of these are benefits to our society, but they're all going to come at a cost. The other thing to be aware of is that resources have alternative uses. So I speak a lot about resources within the healthcare system, but we have to always remind ourselves that what we could be spending on providing bed nets to a community could also be spent on providing access to primary education, providing trained teachers, or paving that road that will allow a village to access a bigger city and provide trade for a community that might be cut off from a bigger area. Sorry, I should have been forwarding through that. So what is economic evaluation? Again, the premise that's underlying economic evaluation or the need for it is that resources are limited. And the main aim or the goal of economic evaluation is to achieve the maximum health gain for the amount of resources that are available. It's a method. It's an explicit set of criteria and tools that are used consistently that allow you to compare your costs of an intervention or a program or a treatment and your effects, the gains, the health gains that you're getting out of that program or that drug or that treatment. This last point about economic evaluation really being linked to real-world policy decisions that are being made is quite important. And what I mean by this is trying to make that distinction between what a clinical trial generally tries to get out of, which is efficacy, so looking at the efficacy of a drug or a treatment or a program, versus the real-world effectiveness of something. So if you actually roll out that vaccine or that drug in the real-world setting with limited coverage, with people deciding not to adopt it, with people not taking their drug on time, or not being vaccinated at the appropriate time, what's the real-world effectiveness of this program or this treatment? And so in economic evaluation, we're trying to put into our models that effectiveness estimate as opposed to the efficacy estimate. And I'm not going to talk too much about that. I think there's a session later on in this conference about measuring efficacy using observational data or clinical trial data. And so I'm not going to be focusing on that at all. I just wanted to highlight the different types of economic evaluations because you probably hear a lot of the different types sort of thrown around and talked about in different senses, and there are distinctions between things like cost effectiveness and cost utility analysis and cost benefit analysis. So I just want to very briefly walk through some of these distinctions. These are the four main types of economic evaluations. At the top you have cost minimization, which is a very simplest type, and essentially what we're doing is we're not even thinking about outcomes. So we're looking at two different programs or interventions, and we're assuming the outcomes are quite similar. The outcomes are not quite similar, but we're making the very strong assumption that the outcomes are the same for those two particular interventions. And we're only looking at the differences in costs. And so we're saying we're getting the same outcomes, we're going to choose the treatment or the intervention that has a lower cost. So our decision is essentially to adopt the least cost alternative. Cost effectiveness, on the other hand, our outcome measure, what we're thinking about in terms of dollar per something gained, is generally a natural unit of consequence. So we tend to think about things like a life year averted, or a case of cancer prevented, or a vaccine coverage, for example. So it's in terms of a natural unit that is relevant to a particular disease area, for example. Cost utility, on the other hand, sort of takes us a little bit further in terms of our outcome measure. And in this case, what we're using outcome measures that you may have heard of, you probably are familiar with, QALYs and DALYs for the most part. And I think there is going to be a session later on in this conference on QALYs and DALYs. And essentially what these measures are, we talk about them as economic measures. What they are is they're an overall composite measure that takes into account not just quantity of life, but also quality of life. And there's a whole lot that goes into developing these measures. I'll talk a little bit about them. But they try to capture society's preferences for different health states. So how people feel about living with a type of cancer versus living with depression, for example. Finally, I'm not going to talk too much about cost-benefit analysis, but what we do in cost-benefit analysis is even go one step further. So beyond putting societal preferences onto the health states that exist in the world and the health that people experience, we're going one step further and actually putting a monetary value on these health states. And so our results are summarized in terms of monetary value, so we can actually compare dollar to dollar. We can compare the financial costs that are going into doing something or achieving something, and the gain, the health gain that comes out of it in terms of a dollar to dollar approach. I'm not going to talk too much about it because it's not as commonly used in healthcare, primarily because there's a bit of resistance in terms of placing a monetary value on a life lived or on a disease, a health state. And so these two, cost effectiveness and cost utility analysis, are more commonly used in the area that I work, in health. So how do you go about doing a cost effectiveness analysis and getting a result? What you're really doing is bringing your costs and your outcomes together into a ratio, which we talk about an incremental cost effectiveness ratio. And it's really quite simple. So you have your costs on your numerator, your outcomes on your denominator, and you're looking at the difference in costs between one alternative and another alternative, and the difference in outcomes between one alternative and another alternative. So I'm going to stress that it's an incremental ratio. So there's always some sort of comparator. You're not looking at a treatment or a program or a policy all on its own. You always need to be comparing it to something else. And so you might be wondering, why not just have an average cost effectiveness ratio where you have the costs of something and the outcome is on the denominator and you're not subtracting anything, you're not doing an incremental. So to give you a bit of an example, think about a pap smear every 6 months to avert cervical cancer down the road. If you think about just doing that every 6 months, it's quite good value compared to doing nothing. You're preventing a lot of cancer 20 to 30 years down the road, which has a lot of costs and a lot of, obviously, detrimental health outcomes. But when you compare it to doing a yearly PAP or doing one every 2 years, for instance, there's actually very little additional benefit. And so you need to think about the appropriate comparator to be looking at when assessing the value of an intervention. The second thing I want to note is that in the numerator, it's quite easy to think about subtracting out costs, dollars and dollars. But in the denominator, if we think about subtracting out outcomes, we need to make sure that we have a common outcome measure. So we can't be comparing outcomes in terms of cases of depression averted, subtracting out cases of cancer averted. We can't just subtract those two out. So we always have to be talking in terms of a common outcome measure. So in the case of cost-effectiveness analysis, there's a whole range of possible outcome measures that could and have been used in terms of producing $1 per case averted of some sort of disease, or $1 per life year gained, $1 per child covered by a certain vaccine, using vaccine coverage rates. And there's a whole range of outcomes that are possible to use. There's some limitations with this, as you can probably imagine. And so, first of all of these measures are quite narrow, and they're unidimensional. They're just capturing one small aspect of a disease, potentially. It doesn't, as I said before, allow you to compare across different outcomes as well. So you might have one program, for example, a maternal and child health program that has visits to a newborn and the mother in the early days, where there's benefits to the newborn in terms of better feeding, making sure the newborn is protected with vaccines, but there's probably also benefits to the mother in terms of maybe lower postnatal depression, and a lot of other benefits that you're only able to capture one type of benefit. You can't capture different types of outcomes. The other quite important aspect, if you think about prioritizing across the entire healthcare sector, is that it doesn't allow you to compare across disease areas. So how do I know how much I should be spending on one type of disease, on diabetes, for instance, versus how much I might want to spend on mental health? And then the final very important aspect is that I don't know the value of what I'm willing to spend to reduce X number of cases of diabetes, or to increase vaccine coverage from 70% to 80%. I don't know the value of all of these different outcomes that I could potentially be measuring. And so that sort of brings us to cost-utility analysis, which tries to get around and address some of these limitations in cost-effectiveness analysis by using QALYs or DALYs as an outcome measure. So I just want to briefly mention what QALYs and DALYs are, and if you're interested, I think you should go to that other session that I think is happening tomorrow. This is sort of visually what a QALY would look like. And essentially what it is it's a measure of time, a length of time, but it's adjusted for quality. So that's very simply what it is. It's an amount of time lived, but what we're doing here is we're adjusting it for some measure of quality of life, which is a simple scale from 0 to 1, where 1 represents perfect health and 0 represents death. And so if we're thinking about an intervention, a health intervention, compared to our comparator here, where we'd experience a worse quality of life, we'd experience fewer life years lived, our QALYs gained would be that shaded area in between those two health profiles. DALYs are similar to QALYs, but they're sort of, you can think of them as the opposite of QALYs. So whereas QALYs you want to gain as many as you can, DALYs you want to avert as many as you can. So DALYs are a measure of ill health and longevity. So they take into account length of time lived and disability or diseased health states. And if you want to know more about DALYs, there's a great website that you can go to. This is part of the Global Burden of Disease Project. which you can select any country that you want to look at or compare different countries. You can look at the main causes of ill health in those countries. You can see how things have changed over time. You can see how priorities in terms of the ranking of different diseases have changed over time as well. And the Global Burden of Disease project uses DALYs as their outcome measure. And finally, as I mentioned, cost-benefit analysis takes us one step further and actually monetizes our health outcomes. And so you have an actual net monetary value of an intervention or a project. So if the amount of money that you're gaining in terms of health outcomes outweighs the amount of money you're spending, it's generally a good idea to be doing that sort of intervention. And one of the benefits of cost-benefit analysis is that you can compare across different sectors. So you can not only just look at health, but you can look at the educational sector, you can look at transport, you can look at a whole range of other sectors and see whether it's worth spending money in one sector or another sector. But as you can imagine, it's quite difficult to actually place those monetary values sometimes on your health outcomes. So to come back to cost effectiveness or cost utility analysis, this is how our results are generally displayed in a cost effectiveness plane, where on your y-axis you have costs, your x-axis you have your efficacy measure, your effectiveness measure. And in this quadrant up here, your intervention costs some money, but it provides additional health benefits. So note in the middle here, this is not zero, but this is your comparator. So you're doing your incrementals again. Down in the bottom quadrant here, your intervention is more effective, but it is actually saving money. It's not costing money. So we say our intervention dominates, and essentially this is sort of the no-brainer solutions where you would do the intervention or implement the program or the policy because it's saving money and it's producing health benefits. Up here, the existing treatment dominates, so you're spending money and getting less. And then down in this quadrant here, which is a little bit less clear, you're saving money, but you're also not getting as much health benefits. And so it's a little bit tricky to know what to do in that quadrant. But generally what we do, most interventions that we assess would be up in this quadrant. You plot the incremental costs up here and the incremental benefits. And that slope from the comparator to that point is your incremental cost effectiveness ratio. So I just wanted to very, very briefly go through a few examples of how cost effectiveness analysis is sometimes applied in the healthcare, in global health. So these are some projects that I've worked on. I'm not going to go into them in detail, but I just want to give you a sense for how these tools can be used in global health. So the Mexico Prioritysetting project is the first one. And essentially, this was a really interesting, great project which involved assessing the cost effectiveness of a whole range of different interventions across different disease areas. These involved not just medical interventions, but also community and public health interventions, and allowed us to compare them all together. So each point here actually represents one strategy, one drug or one intervention that was assessed. And the goal of this project was to try and help the government set their priorities for a national healthcare system. So 50% of the population had no health insurance at the time that we were doing this project, and the government was rolling out a social health insurance project and wanted to know what to put within their package of interventions that they would be offering. And so some of this work helped to inform what went into that package of interventions. This project, obviously, I'm not going to go through it. I just wanted to show there's one thing I'm going to tell you about the colors, but this was a project looking at maternal mortality reduction strategies in several different countries around the world. This particular figure is from the India paper. But we looked at increases in family planning, we looked at access to safe abortion, we looked at investments in, obviously, emergency obstetric care and in-facility deliveries. And the color coding just shows the differences in how cost-effective different strategies were relative to other strategies. So that's what the color scheme corresponds to. So from cost saving all the way down to cost effectiveness ratios, about $800 per DALI averted. And finally, a project that I've been working on very recently and hasn't fully been finished yet is a project that was looking at introducing new vaccines in 4 Pacific Island countries. This was funded by the Asian Development Bank and essentially involved vaccines that we all have access to here and most developing countries have included within their national schedules, but aren't always included in low and middle income countries. And so providing governments with the information on how cost effective each of these vaccines are in order to help them make those decisions. I want to end with just pointing out a few of the current challenges that exist in cost effectiveness analysis, and just literally just touching on them. So there's the issue of cost effectiveness thresholds. How do you know if something is cost effective or not? Well, what about the budget impact? So something is very high value for money, but it's actually very expensive and may not be affordable for a country to roll out to everybody. And then the last issue is issues surrounding distributional effects and equity considerations. Who's benefiting from these interventions? You may have heard, if you work at all in this area, that equality is equality is equality. So equality that you would gain is the same as equality that I would gain, or someone who's very low income, or someone in a different country. And there's a lot of issues, obviously, as you can imagine, about that particular aspect. There's different thresholds that exist across different countries, and some of these have been in place for a long time, but some of them there's a lot of controversy around whether these thresholds are actually appropriate. And there's a lot of work at the moment to try and better fine-tune these estimates and understand them a little bit more. In terms of budget impact, there's a lot of work at the moment as well about trying to get cost effectiveness to actually take into account affordability considerations and budget impact of something. So not just look at value for money, but can we actually afford this? And this is very relevant for low and middle income countries, as you can imagine, with very limited resources. And finally, there's a great paper that looks at equity criteria that are important but are generally not captured within cost effectiveness analysis. And I'm not going to go through the different groups, but they capture a whole range of equity criteria that are important. And I just want to end with this graph that I thought was, this is quite new. This came out of a recent paper, which I quite liked because it takes our cost effectiveness plane and essentially adds in equity considerations. So not just talking about cost effective or not cost effective, but how does it do on equity considerations? Does it improve or does it hinder equity? And talks about whether we're in a win-win situation or win-lose, or essentially allows you to consider equity alongside cost-effectiveness analysis. And so that's pretty much it. Thank you very much.